start recording. That freaks me out every time because that is a new thing.
Yeah.
And yeah, I am going to pass on to the lovely Angela Sharma. So I will make you host.
Thank you. Okay,
there we
perfect.
go.
So I'm just going to set up the slides. And okay. So hi everybody, thanks for coming to the meeting. Angela and I are from Pear Health, and we're going to talk to you today about endometriosis and menopause as well. So let's just get started. 1 second, why is this not working now? There we go. Just a quick introduction into who we are. So I'm Angela Sharma, and my colleague here is Dr. Angela Wright. We're co-founders of Pear Health. This is a online menopause and sexology clinic that is going to be starting hopefully in late summer. We're just waiting for our CQC approval, and then we're ready to go. We're both GPs, and we have a real interest in women's health, and in our own surgeries we run menopause clinics. We are trained in 2 areas with extra qualifications. We are British Menopause Society advanced menopause specialists, and we have also training in sexology, both in the psychosexual side and in the medical aspect side. So a little bit of extra specialities there. So what are we going to talk about tonight? So first of all, we're going to start off with talking about menopause and kind of things that you need to know about it, a little bit of introduction there. I'm going to go into talking about HRT and breaking it down into sort of the different types, and trying to bring in endometriosis wherever I can in terms of discussion about HRT, understanding risks and benefits, which is really, really important. And then I'm going to hand over then to Angela, and she's going to talk to you about all the other different types of treatments and things that you can have other than HRT to help you going through the menopause. And then part 2, hopefully we'll take some questions, and if you can, like Jodie said, post them in the chat, or if there's anything really burning, then just Jodie can ask me or Angela as we're going through. And just at one point, just to say that when you do ask questions, it's really difficult because we can't give individualized medical advice, because the way that we do that is looking at all your family history, medicines and things like that. So if you can keep it generalized, that would be great. Okay, so first of all, sorry, someone's trying to come in, so just going to let them in. Just to talk about menopause. So there's lots of different terms that are used when we talk about the menopause. So I'm just going to simplify them. So menopause is the last period, and you are only in the menopause once you've not had a period for 12 months. Everything before that is called perimenopause, and everything after that is called postmenopause. So actually you're only in the menopause for 1 day. So that's quite nice. Most women go through, there's different types of menopause, but I'm going to just talk about normal menopause first. So most women go through menopause through the ages of 50 to 51, and it's a gradual process that takes a couple of years. And initially what happens is you start having this fluctuations of your hormones, of your estrogen, progesterone and your testosterone. And what happens if you liken it to like being on a roller coaster? So for some days your hormone levels might be high, some days they will drop really low, and then they'll be normal. And it's just this up and down sort of series of hormone fluctuations but generally what's happening is all of these hormones are getting lower and lower. There'll be a time where eventually you'll get to a certain point where the hormones actually become so low that everything starts to shut down, and that's when the periods stop. This fluctuations of hormones can cause a huge amount of physiological sort of symptoms and impacting on all parts of your body. So not just physically, but also these impacts can also have a social effect on your relationships, on your work, and also psychologically. It can affect a lot of women in terms of their mood and how they feel about themselves and aging and just generally it's not a great time. But we're going to talk about how to help you through that anyway today. There are some women who go through early menopause, and that would be between the ages of 40, 45. This would still be a natural sort of process, and these women would be just termed a little bit early menopause, but it's still the same process as the normal menopause. And then there's another group of women who go through menopause very, very early, below the age of 40. It's about 1 in 100 women. And these are termed premature ovarian insufficiency. In this group of women, this going through the menopause at that stage can have such a devastating impact on their fertility, on their mood, on their symptoms. Just as they're trying to come to terms with all of that stuff, it can have really quite severe implications. I just wanted to talk also, and to be inclusive, and maybe for some of the women in the group as well, to talk about sort of special cases of menopause. So there are some women who will go through surgical menopause. So these are women who will have their ovaries removed for whatever reason. It might be endometriosis, it might be something else, some other reason. And the problem with this is this gives a really severe and abrupt sort of menopause. And these are the women that kind of go into shock sometimes, because we find when we see these women in clinics that no one's really told them that this is going to happen. And it's really upsetting when we get to that stage. Some women will go through an induced menopause, and this might be very well the women with endometriosis, where they've had to have all their sort of hormones shut down, and this is with certain drugs such as Zoladex or Prostat. There are obviously the women who are going through not just breast cancer, but any cancer treatment, and that can have a damaging impact on their ovaries and on hormone levels. And again, this is quite sort of sudden and severe symptoms. And you just feel so sorry for these women that they're going through all of that treatment, and then they have to deal with the menopause as well. And again, we're finding that, these women aren't told that this is going to happen to them, and they're just in huge shock as well, and just sometimes quite embarrassed to sort of be coming to a doctor about these things, because they feel like they should be happy that they've just got over their cancer, or they should be happy that they've survived their treatment, but then they're going through all of these terrible symptoms. And it's just really important that all of these things, just to be aware that they have huge impacts, obviously, on fertility for some of these women. Losing estrogen at a very early age, or through these processes, can have a huge impact on your bones, on your heart, on your risk of heart disease, on your memory and things like that. And also, very, very important, and very few people sort of talk to women about it, is their impact on their life and work and relationships. But we will be talking about that as well. So what are the symptoms of the menopause? So there's lots of symptoms. I think there's about 34 at the last count, and it keeps changing. More and more symptoms are being added. But what we do is try to divide them into sort of different groups of symptoms, and they're vasomotor, psychological, genital, sexual, and skin and joint symptoms. And a lot of women ask, well, when I'm going through the menopause, can't I have blood tests to have check when I'm going through the menopause? So generally, the advice from NICE is not to do blood tests in people going through normal menopause, and to base it on symptoms only. The general reason being is, if you imagine going back to that roller coaster of hormones going up and down, wherever you check the hormones, at some point, if you check it when they're high, they might be normal, or sorry, they might be high, or they might be normal, or they might be low. And you can't, if you've checked it and the levels are normal, you can't say then someone who's got all these symptoms hasn't got menopause. That's why they've advised us not to do it. Definitely for the women under 45, I would think about doing some hormone blood tests or other tests, just to make sure that I've not missed something else, like a thyroid problem or some other condition. Also, having said that, I do tend to do a set of blood tests for women that come to me, and it's just because I like to use that menopause consultation as a pit stop, just to talk about not just about menopause, but about their general health and their long-term health. So I like to look at their cholesterol, I like to look at what their blood count's doing, what their vitamin D's like, calcium levels. And it's a really great way for me then to talk about their general long-term health as well as menopause. But that's just me individually, but you might not get that from your GP. So going into each section, so vasomotor symptoms, these are ones that most people know about: the hot flushes, palpitations, feeling dizzy, faint, and a lot of women who have migraines suddenly get an increased history of migraines. And just saying, with all of these various groups of symptoms, what you might find is some women just present with one or two of these symptoms to the GP, and it might get missed. So a woman might just present with just, I've got, my migraines are getting worse, and they might not mention some of the other symptoms, and so they might just get put on migraine treatment. Another lady might come and say, I've got low mood, and get put on antidepressants. So it's really easy to miss a lot of the symptoms in menopause unless you're going with all of them to the GP. So what I would do is probably list all the symptoms that you're going through and present it like that to your doctor. But sometimes what happens is some of these symptoms appear, like one week you might have hot flashes, another week you might have migraines. So even if patients themselves, they don't realize that they're going through the menopause. So it's just something to be mindful of. Just to explain why we get these vasomotor symptoms. So in our body, if you think about it, we have something called a thermonuclear regulation zone. Quite fancy term, but I would liken it just to like a thermostat. So you have a lower temperature and a higher temperature that your body works with. And if you go below that temperature, then your body will kick in your sort of shivering mechanism to sort of warm you back up. And if you go over the temperature, then it will make you sweat and try to cool you down. And then what happens with these dropping estrogen levels is it kind of narrows that thermostat range. And so a temperature that maybe you would have been fine at before, suddenly you're feeling really hot and you're not in tune with all the other people in the room. So this is the cause of it. Just understanding that sometimes just really helps people, to come to terms with some of their hot flashes. I think Angela's going to talk about that later. And just another point to say that stress will make everything worse, and all of these symptoms, vasomotor symptoms, will make it worse. But Angela's got some tips for that later on. Musculoskeletal skin symptoms. So estrogen it's kind of vital for your normal collagen production and your bone health, and it can cause sort of joint aches, muscle pain, stiffness, tingling in hands and feet. But there's something that's really, really important to realize is when you go through perimenopause, and as that starts, our bone density starts to fall. So estrogen protects women's bones from becoming thinner. And as you go through that perimenopause and menopause stage, then the bone thinning actually accelerates, and you lose quite a sort of significant amount of bone mass at that stage. And so it's really, really important to be aware of that. And Angela's got some tips later on for that as well. And just sorry. Yeah.
No, I was just going to jump in there, because obviously endo is very estrogen dominant. It relies on on estrogen to thrive.
Yeah.
So if we're trying to sort of eliminate estrogen from an endo person, is there any way we can get around not using estrogen and using something different? Or
yeah, there are some things that you can do for your bone health. There's a whole slide about that later on. So Angela's talk about it, because there's a lot of women who can't have HRT, so women with breast cancer. Even for them, it's even more important to look after their bones, and we've got some tips later on that every woman can do, definitely.
Brilliant.
Just a quick mention about skin, because everybody gets a little bit worried about this, and as that estrogen drops as well, you don't have that collagen production, and so skin becomes drier, itchy. It is a time that women might notice a lot more wrinkles in their skin, and and their face starts to fall. But it's one of those things that I'm afraid will happen to all of us as we age. This slide's really horrible. It's like all the psychological symptoms, and every time I look at it, I feel really sad that these are all the symptoms that can happen to women. Not everybody will have all of the symptoms, but I'll just pick out one or two. Definitely, it's the low mood, it's the brain fog, it's that feeling tired, and generally just not being able to cope with the things that you were able to cope with before. And the way that most women will say all of these things is, I just don't feel like myself. And that's a really, really important line. If any woman comes to me and says that, then I just start thinking about menopause straight away, like what's going on. So, sorry, I'm just, I don't think anyone's coming in. Let's just go back to my screen. Just also trying to understand about what happens in the brain. And I think this is Angela's real area of expertise. So I'm just going to hand over to her to go through this slide, because she's really interested in this stuff.
Yeah, this is my bugbear, because I have issues with progesterone sensitivity and with PMT, PMDD. So, and it wasn't taught particularly well to me at med school, and as a doctor before I did this sort of training, I wasn't really aware of it. So I always like to talk about it. And this is just that we're starting to understand that some women have got an inbuilt or an inherited tendency to react quite differently to progesterone than other women have. So for most women, progesterone's effect on the brain is to make you sleepy, it calms you, it's quite a sedating hormone. When we give HRT, we give it at nighttime because it helps you to sleep. But for about 1 in 10 women, the brain seems to respond to it differently, and you get mood change, really negative mood change. And so these are the women that may have struggled with their mood. Yes, someone's saying they're horrendous on progesterone. So this is also me. So difficult years in teenage years, often issues after having pregnancies, and you can look forward to difficulty with menopause as well. And you tend to get less good days as you get older. The sort of part of your cycle where you struggle tends to get a bit closer, and you spend more of the month having an issue. So I like to talk about it because I want women to understand this isn't some kind of weakness or inability to cope. This is something genetic. Your mum has often got it, your daughters may well have it, which can mean that the household can, most of us, when we go through menopause at the natural age, it's pretty much when any daughters that we have are at teenage years as well. So it can become a real issue in the house. But we've got to be careful with these women because certain forms of synthetic progesterone that are in some forms of HRT and some pills will make you feel bad all the time. So being aware if you're progesterone sensitive or if you've got a history of premenstrual mood change. And yeah, exactly. So someone said that they've been started on Nutrigestan, and that is P4. It's progesterone that is exactly the same as our body makes. And because a lot of the issue that we have if we're progesterone sensitive and having PMT is that fluctuation, that up and down as we ovulate, actually with HRT, we're giving you a steady amount a lot of the way through the month is what we're aiming to do. So it's not always the same, but it's just something to raise with your doctor if that's something that you've got a problem with. And I put this slide in because I don't think women are often aware that that's the story of what's been going on for them. I'm going to hand back over to you now, Angela.
Yeah, thank you. So the next sort of set of symptoms are the genital, urinary and sexual symptoms. And generally what happens in that vaginal tissue is very, very sensitive to that drop in estrogen, and you tend to get the tissue becoming thinner, you get more infections, and because it becomes thinner, it becomes drier, and so it becomes painful to having intercourse. It's also important to know that it becomes the tissues and then around the clitoral tissue, it becomes less sensitive to sexual touch. So you might take a longer time to get aroused because the vaginal tissue becomes less stretchy inside. It becomes really painful when you're having intercourse as well. Also, loss of libido is a huge symptom that a lot of women feel, but it's not just to do with hormones. It is to do with hormones, but there's so much more to think about. And that's where our sexology training comes into it. And it's something that we take really seriously in our clinic. Also, just to know that there's less blood flow in that whole pelvic area. So you tend to get weaker pelvic floor muscles, and that's when women will tend to notice more things like incontinence or prolapses at that stage. So how long does it all last? This is a good question. In the past, people used to say it's a couple of years, don't worry, it's just a couple of years. But half of women are still having it, about 7 years still later. It varies in women, and there's no set time, I would say. And I generally tend to say about sort of 4 to 7 years, just to make sure you cover all those women that are still going to carry on. And then there's a small subset of women, just less than half, that are still having symptoms. I see women in my clinic, 60s, 70s. I've just seen one who's 75, desperate to go back on HRT because she can't cope with the hot flashes. So who those women are going to be, you just don't know. And you just have to take each woman's history sort of one by one and see how they go. And generally the advice is that there's no cutoff limit to stopping HRT. And it's something that I would discuss with each woman at our annual kind of HRT or menopause review. And I try to sort of look at each woman individually in terms of her risks, benefits, how she's feeling, how long she's been on HRT. So that is a really important discussion to have with each woman.
See, that's really interesting because like my mum had to have a hysterectomy at around the same age that I had my hysterectomy.
Yeah.
And she's just turned 57 and they've taken her off her HRT. And she hates it. She's having a really, really, really tough time, but her doctor won't listen to her and won't let her go back on it. but her mental health is she's really struggling.
So with that kind of person, I would bring them in, I would try and find out what their symptoms are, how much it was impacting them. And then we would look at the risks for that person individually. Because as you get older, the risks of breast cancer, heart disease, diabetes increase. And it's just about explaining that risk to that person and how much that risk is and how much it's impacting on their life. And so for some women, I would restart them on HRT. So the lady who's 75 knows that there's such a huge risk of breast cancer at that age, but she's adamant she wants quality of life. And, I've explained the risk clearly. She's happy to take it. So she's a very happy lady now.
Oh, that's fantastic.
Yeah.
I think it's important to say as well that it's the background risk that's gone up, that in terms of it's your background risk of breast cancer that's gone up when you're in your 70s. HRT hasn't suddenly got more risky. Angela does a really good job of talking about levels of risk, and you've got kind of like the level that you get from just your age, then your family history, and then there's the other things that are going on. HRT only adds a small level to whatever your existing risk is. It's just that when you're in your 50s or your 40s, you're starting from a lower point. By the time you're in your mid 70s, it's getting more likely that something's going to go wrong. But like you say, it's a balancing act because it's actually protective against heart disease. So for individuals, women, it could be the right thing to do.
Yeah. Sorry, I've lost my page.
And sometimes it can be a case of people's mental health is more important than their physical health. Like
I think you have to look at them as a whole. You can't just look at one sort of part of their body. You have to see how it impacts everything. Yeah. And asking them about work as well and relationships and everything.
Yeah. And treating them like a grown-up. I think we always say that it's not necessarily down to us to make the decision for you. We're here to help you to make sense of the science that we've been taught, and actually the decision lies in your hands. So in menopause clinic, in secondary care, we get people referred in that GPs don't want to hold that risk of putting them back on again, and your mum's GP may not want to hold the risk, but if she gets referred on, somebody else will do and will explain it. So it's worth talking to someone about that.
I think it's really important for more people to know that these menopause clinics are out there, because there's so many people don't know. So many people aren't aware of them, and it's the same with the endo centers. Like not enough people know that there is a thing that exists that could potentially help them. And it's another one of them things of why are we not shouting this from the rooftops, because it's an amazing service.
I think that's why me and Angela set this service up, because it's something that we offer in our clinics, and people are so thankful that there's someone there in that practice that has the knowledge and the confidence to prescribe HRT. And we just felt that this is something that we should definitely offer to other women as well.
Because you're right, there is that postcode lottery with it. If you can't be referred to somewhere, then you are sort of stuck. And there still aren't enough menopause specialists nationwide. There's not a huge number.
Yeah. It's women's health in general, isn't it? But we won't get back on that soapbox.
We could say a lot about that, but just sort of summarising, what I just wanted to say here was just really that the symptoms of menopause are very, very real. And people need to take them very seriously, as in doctors anyway, when someone comes to them. They can last for quite a few years, and because of the impacts that it can have in terms of your general health, long-term health, it's really important to take them seriously. There's a lot of things that we can do, and Angela's got loads of tips of, I'm going to just talk about HRT in a minute, but there's loads of tips of general health that we can say to you today that you can take away with you. And also definitely that endometriosis is not necessarily a reason to avoid HRT. So I'm just going to go into talking about HRT. So what is HRT? HRT is just generally, as you're going through the menopause, the hormones that you're sort of losing or dropping down are your estrogen, progesterone, and your testosterone. And so all we're doing with HRT is just giving you a very low level back, enough to control your symptoms, and also to give you the benefits of HRT, which I'm going to talk about later. But generally it's natural. We tend to use natural estrogens. The ones these days are made from yams or soya. Also, depending on whether you have a uterus or not, we would add in either a synthetic or natural progesterone. I tend to generally use natural progesterones these days. If you've had a hysterectomy, then already, then you don't need the progesterone, but I would say to be cautious about that in someone with endometriosis, if they've still got maybe tissue that's still there that could be active, and that's something I'll talk about a little bit later. There's lots of people talk about systemic and topical HRT and get all confused. So systemic is the one that you take in that affects the whole body, and it can come in various different forms: tablets, gels, sprays, patches, pellets, all sorts of ways. In the old days, they only really had tablets, but nowadays we've got a bigger variety. Topical HRT, when I use that term, I mean the estrogen that you can put inside the vulva and vagina only. And then there's another term which is not on here, but transdermal, and that's the one that's the more natural estrogen, and it comes in the forms of gels or sprays or patches. There's also tibolone, which is an interesting drug. It's kind of like the building blocks of testosterone, estrogen, and progesterone, and it's quite good for a lot of women with endometriosis, just because you get that really steady level of all the hormones. And then at some stage, you might or might not need testosterone, and that's something I'm going to talk about in a little bit as well. But generally, most women under the age of 45, because of the risk to their long-term health of osteoporosis, of bone disease, and heart disease, and diabetes, and memory problems, we would definitely recommend that you use it. Above the age of 45, it's a choice and it's a discussion. And like Angela said before, it's something that I make sure that I discuss properly with my patients, make sure they understand all the risks, all the benefits, all the different types of HRT, and then I let them decide what they want to do. It's not pushing someone towards something or anything in it, but I feel happy once they've made that decision, because I've given them all the information about it, and giving them a chance to ask questions as well. Not moving forward now. Hang on. There we go. So there are some people who should never have HRT, and never, but maybe, but as well. But so estrogen dependent cancers, so obviously anything that feeds a tumor that's estrogen dependent, you can't have that. Having said that, there are some women, again, like talking before about some women who've had breast cancer who are absolutely desperately suffering. I have started in my actual secondary care menopause clinic on HRT, but this is a really important discussion with your oncologist, with the menopause consultant, and with the GP and with the patient, so everyone's on the same page. Anyone having undiagnosed vaginal bleeding or changes in their pattern that might not be menopause need investigating first. Pregnancy, definitely a no-no, but it's really important that there's a lot of women to understand that who are going through IVF at a later age and might come out the other side and be already perimenopausal, and they're going to be breastfeeding, and you can actually start HRT. It's safe to use in women who are breastfeeding. Active liver disease or people with abnormal liver tests, I would also be cautious about. And then anybody with a current blood clot, DVT or pulmonary embolus, or any recent heart attacks, I wouldn't be putting them on the HRT. So there are lots of other caveats about different conditions, and this slide is just to say, just to show that there's lots of different things that some GPs might not sort of prescribe HRT for, but actually you can have HRT. It's just about thinking about the right type of HRT for you, and being confident enough to sort of prescribe it. But that's because Angela and I have been trained in this. We know the knowledge, we know the evidence behind it. But generally with endometriosis, it's more about the progesterone and having any residual disease and not making it active again. And then so what really helps is having that sort of steady level of hormones with patients with endometriosis. Fibroids, just lower doses, high blood pressure. So HRT doesn't cause you to have a rise in blood pressure, but it also is really important to have your blood pressure under control before you really go on to any HRT. Migraines, we definitely use it, and with people with clots as well, and epilepsy. But all of these, we would use a transdermal version. So that was the patch or gel, just because it doesn't get processed through the liver, which is what makes the blood a bit more sticky. Again, like I said before, women over 60, we would just be a bit more careful. We would also try to use a much lower dose because they don't need that much estrogen at that stage. But it's not a no for them either. and family history of breast cancer. Again, I would discuss that at the risk. And definitely women with a high BMI over 30, a lot of GPs wouldn't prescribe HRT just because they're worried about the clotting risk. But again, you can bypass that with using a patch or gel. So the different types of HRT. So I did mention transdermal. So transdermal is the gels and sprays, and this is quite nice because they have a better breast cancer profile risk, and you tend to get a steadier hormone level. So it's for controlling a lot of the women's symptoms. Oral, this is what we used to use in the old days. I do use this sometimes in women who don't sort of suit well with transdermal, but this involves digesting it in your body, and that's what leads to the variable doses, and that can lead to variable hormone levels and days, so the symptom control is not so great. There is some evidence that it's better for heart disease protection, but there's some people that feel nauseous with tablets, and just to know that some of them contain lactose, so if you're lactose intolerant, then you might want to be avoiding that. So progesterone. So generally before we go through menopause, when you're having a normal cycle, your estrogen and progesterone would rise, the lining inside would build up, and then as they drop, that's when you would have your period. And what you don't want is on people who have a uterus is just having estrogen on its own, because it's just going to overstimulate the lining, and then you're not going to have that period with it. And what happens is when you overstimulate the womb lining without the progesterone, there's a risk of that the cells can change and cause endometrial cancer. And that's what we're trying to avoid. So women who are having estrogen, and if they have a uterus, should be on progesterone as well. There's different ways of giving it, sequentially and continuously. Sequentially, I would always go for women who have periods and who are still having periods, because you just want to mimic that normal cycle still. And so they would have the tablets just for maybe the first 12 days of the month, and then their period would happen just towards the end of the tablets or just after. And in some women with endometriosis, obviously you don't want that to happen. That's the thing you're trying to avoid. So we do sometimes give the progesterones for 3 months at a time, so cycling it for a bit longer before you have that break. For women who periods have stopped, we tend to give the progesterone continuously, and this would be a daily lower dose. There's other ways of having progesterone as well, and then Mirena coil is one. It's fantastic because it's a contraceptive as well. So if you need contraception, then that covers two things, and it's also the progesterone part of your HRT. Once you have it in, it lasts for 5 years. Obviously, there's a lot of discussion these days about fitting Mirena coils and pain, and lots of people are talking about that. But maybe Angela can say something because she just fits coils herself.
Well, I see. My experience is that people always say, "Oh, you're very gentle," and I think it's about proper explanation. I tell my women to take painkillers about an hour beforehand, and tell them there's going to be a couple of moments where it can pinch or cramp, but that they're in control, and if they want to stop or if they've changed their mind, that's their decision. So I keep them in control, and I use local anaesthetic jelly. I have to say, my experience of fitting is, it's probably 1 in 50, something like that struggle with it more. And it's not the people that are difficult to fit, actually. It's not that it's technically difficult. I think my training talks a lot about trauma and things that we carry with us. And I think we underestimate how many women come into the room with either historical sexual traumas or medical traumas, or have been through lots of horrible gynecological experiences. And I think a lot of that is possibly what's going on, and the anxiety. So I think we should offer pain relief, but I also think it's like with everything, it's putting the woman in control of what's happening to her body, treating her like a grown-up, and that's where I think most of the problem is.
Yeah, we have a lot of people on our support group that do really struggle with the Mirena fitting, and like you say, there are so many that have been through trauma beforehand because of either painful smear tests, painful hysteroscopies and stuff like that, that when they do come to having the Mirena fitted, that it's like there's horror stories, and Katrina won't mind me saying this, there's a story of people having it fitted and sitting bolt upright and vomiting all over their
or fainting.
Yeah.
I think there's I've worked where I work now. I'm careful if I'm being dodgy in saying it. I followed in a partner who was sort of old school gynae who just got everything in, and that she saw that as her job, was just to get it in and to do the job. And I think you do better to stop and to keep watching the woman attached to the cervix. I think so many times people forget that there's a human being behind the job. I was going to say, and I think I've had one or two where I've just said they've obviously been uncomfortable and we've just abandoned it and gone for something else. And I think that's as long as that's always the option, and the woman's always in control. But sadly, there are definitely people that see it that they've got to get it in and get on with it, and that I think does women no good at all.
Yeah, having that control is massive. It's a massive thing. And like I've heard about there being some people that are allowing people that have been through some form of trauma or painful experience of when they're having their smear, of actually inserting speculums themselves and stuff like that, just to get that little bit of control back.
I think that's completely fine. So I talk because I've been trained in trauma. You can give trauma informed care, and I think I see this a huge amount with secondary care. If I'm referring patients that have got a history of sexual trauma to have something done, I struggle to get people to take it seriously at their end. I've had a situation where I referred a woman in who had PTSD related to historic abuse and spent an hour trying to get a female doctor to receive her at the hospital, and still a man came through the curtains first. There are good doctors and there are people that, I think are practicing in ways that we wouldn't approve. It's important to find your voice and to make sure that you stay in control and that you make it very clear what you're not okay with. But yeah, the practitioners should be really sensitive about this stuff. And if they are, the coil fittings are usually okay. They're usually okay.
I think in my surgery, both of the nurses are really well trained in this area, just because I'm very conscious of it. And we don't really hear those stories about terrible smears in our surgery. So it's about understanding, like just like Angela said, like the person at the other end who's having that done to them. And it's not just with smears, it's with any kind of examination. Explaining what you're doing, why you're doing it. Are you okay with that? It's just really important.
I think people forget how vulnerable you are actually when you're, we all feel like that you're very, very vulnerable when somebody's doing those things to you. And we need to be, I think, respectful of that.
Yeah, and there's this thing again, going back to the whole because it's a woman's thing, you're expected just to lie back, let them get on with it, and just get up and walk away at the end of it. But yeah, it's really nice that there are people out there that do care and put us on the forefront, like Nicola says and Katrina says. Like it's brilliant to know that there are people out there putting the patient first.
I think a lot of it's about training at med school. I mean, Angela, the reason that we decided to do the clinic was because we were so similarly minded. We sort of had we met overseas and we're chatting about it. I think there's huge flaws in the training, and it's ignorance is a big problem, especially around trauma. And I think that's where we've got a massive amount of learning to do in the medical profession, in respecting women's backgrounds, but also men's backgrounds, and making it possible that they people take note and take care around it and don't re-traumatize.
Brilliant. Thank
you. I think there was just one thing on this slide that I was just going to say right at the end, just about natural and synthetic progesterones, and which one should we choose. I tend to always start with a natural, just because it's best tolerated. It's the same as the progesterone in your body. It's a lower breast cancer risk, but some people don't suit it, and then I would definitely then go over to the synthetic progesterones, and they're sometimes better at controlling the bleeding. So when I first start on anyone on HRT, I always do a review after a month, but I do warn them a few things that, if you've not had hormones for a little while, say if you've been suffering your perimenopause or menopause symptoms for quite a while, suddenly adding in a bit of estrogen and progesterone, you're just going to get a huge little, well, not a huge surge, just a surge of these hormones. And so you might get a few sort of side effects. Generally, what I hear from women is a little bit of bloating and maybe some breast tenderness. But when I see them at 3 months again, it tends to all settle down, because now that surge is sort of settled down and become a steady level. And just one thing to point out here is that actually you can see that some of these symptoms are the same on both the estrogen side and the progesterone side. So it is sometimes quite hard to work out which one it is if you're continuing to have symptoms. So, and like with everything, every woman's different whenever you give them hormones, and you just have to see how someone responds and then look at what symptoms that they've got, teething problems, and then see how you're going to sort of adjust that. But it is really important to say that very few women come at this stage and saying that they've got side effects. They actually, I say about 95% of them are coming back and saying, thank God you started me on it. I feel so good. You know, I'm so glad that I went on HRT. But so yeah, I don't tend to hear side effects. This slide is just really important. So whenever you're starting anyone on HRT, what you just want to make sure is that it's suiting them, and just warning them that sometimes hormones do take a bit of time to settle down in the body. So whenever you're starting on HRT, it can take sort of 3 to 6 months for, even if you're on continuous or cyclical progesterone, that it can take some time to settle down. And I don't tend to get too worried about any irregular bleeding in the first 6 months, but anything after that needs to be reported. And so every time a woman comes to me, I'll be checking, like, do you have any irregular bleeding? And by irregular bleeding, I would mean, so the people on sequential bleeding, I'd expect them to have their period just towards the end of the progesterone sort of tablets or just after. Anything outside of that is irregular. And for the women who are on continuous, I wouldn't really expect them to have any bleeding. These things need to be, if it's quite heavy bleeding, like a period, that wouldn't be an urgent referral to the gynae for check the lining. So, and just a point about women with endometriosis, that if you're on estrogen only HRT, because you've had a hysterectomy, if you start getting pelvic pain, that might be one of the signs or symptoms that some of the tissue might be reactivated. And so any woman that's developing pelvic pain will definitely need further investigation. And so I would definitely be referring her to the gynecologist or for a scan or checking things out. When do we stop HRT? So again, there's a lot of people that just stop it because they're influenced by the media. They read those scare stories. They think, oh no, or someone close to them has got breast cancer all of a sudden, and they just get so fearful of it. There's a lot of people stopping it without medical advice. And then if you actually talk to these women, if you've explained it properly to them and you're doing that constant care and checking in with them, then they say that if someone had explained that to them, they probably would have carried on. So it's just really important. And also it's important to know the minute you stop it, and if you're still in the perimenopause or menopause symptoms and your hormones are still yo-yoing, then your symptoms are just going to come back. And just one point about patients with premature ovarian insufficiency, definitely the recommendation is for those women, because all we're doing is just replacing the estrogen and progesterone back that should be there anyway. So we tell those women to take the HRT all the way up to natural menopause, which is 50 to 52. And then if they need to continue on it, that's when we would reassess and decide whether they need it or not. I just want to come back to this one, genital urinary syndrome menopause. So this is the combined term now for women who have the vaginal symptoms or pelvic symptoms or bladder symptoms. And it's just because it's a huge area that a lot of doctors don't talk about, they don't ask the women about, and patients don't want to mention it. And it's just really, really important because people are embarrassed, they don't want to talk about it. It's an area that women suffer terribly with, and all women at some point will have some of these symptoms, and definitely towards the postmenopausal years as that estrogen gets really low. So it's the dryness, the itching, the prolapse, the urinary infections, the sort of thrush and symptoms like that. So just to know that there is local therapy that you can use. That's the topical HRT that I was talking about before. It's estrogen that we would just replace back in the tissues. I don't know if you can see it because I can't see it because of the faces, but there's a little slide here at the side that Angela's put with a normal vaginal tissue, which you can see is really lovely and thick, and it's got nice folds in it. And then just next to it is the vaginal tissue that's in a menopausal lady, which, as you can see, is really, really thin, and it's flat, so it's not just stretchy. So by putting vaginal estrogen in locally in the vagina, it just gets absorbed locally. It doesn't get absorbed into your system, and so it's quite a nice treatment for women who can't have HRT but have got vaginal symptoms. If you really can't have HRT, vaginal HRT, then just to know that there's also things like vaginal moisturizers. This is probably a new thing for a lot of women, but just as you would moisturize your face, it does the same thing down below. It moisturizes the tissue in the vaginal area. It just really helps with dryness and itching and that discomfort. And separately from that would be lubricants that I would definitely recommend around this time if you're going to have intercourse. There's different types. There's water-based and oil-based. Just to say that oil-based, not to use with condoms. And then also there are vaginal lasers, which are a new treatment, but unfortunately only available in private clinics at the moment. But some promising results from that. But I think most women who've got quite severe symptoms, or maybe who've had breast cancer and can't have any of this stuff, or it's not working for them, might be going for that kind of treatment.
What do the lasers do?
And then just
they sound like they're really cool, don't they? You can shoot people with it.
Yeah. So what the lasers do, I suppose, is like a probe that they put inside, and I don't really know exactly how it works, but it just regenerates.
It's radio frequency. It's like, you know, when you go to your aesthetician because you're getting a falling face in your 50s or whatever, and they laser it, or they do those sort of those heating therapies. They induce a little bit of damage to make the body try to heal. So it's, someone just said, does it remove hair as well? No, because this goes inside the vagina, so it's not, that bit's not normally, it shouldn't be hairy, but it's, yeah, it sort of, it forces it to heal, and in that healing process you get some more collagen, you get some more strength in the tissues. So they're called, I think it's the Mona Lisa, isn't it? And they're quite expensive.
Mona Lisa Touch.
Yeah, you need two or three, and I think it's about £1 a pop. It's quite an expensive thing to have done. There's some trials happening in London, and it's largely women for whom hormones aren't an option. So women on certain forms of breast cancer, post breast cancer treatment like letrozole.
That's really interesting.
Some women that have had it, because everybody wants to know, is it going to hurt? And from the women that I've read about that have had it done, they said it's not as painful as you think, but it's a little bit of discomfort. So again, it's another thing just to be aware of. Just going to talk a little bit about testosterone. So there's just some interesting facts that in our fertile years, we make sort of 3 to 4 times more testosterone than estrogen. And testosterone is made in our ovaries as well as the adrenal glands. And our ovaries continue to produce testosterone after the menopause, although a little bit lower level. But so for those women who've had their ovaries removed, then they're going to have the significant effects of that drop in testosterone. And testosterone is the hormone that's needed for all those pathways for libido, for arousal, and to have an orgasm. So this is another area that is really, really important that nobody wants to talk about, but we do, and that's because that's our sexology training. But testosterone also impacts in other areas in the body. It's for your mood and cognitive function, for your bone strength and metabolic function as well. And if I was going to start someone on testosterone, I'd probably wait to normalize their estrogen and progesterone first, and then see if they still had symptoms of low libido. And so if I do add it in, it's probably after 3 months stage of once I've started HRT. Unfortunately, there's no female testosterone licensed in the UK, so we tend to use the male testosterone off license, and it sounds very scary, but it's not. The male hormones come in sachets or a pump, and a man would use 1 sachet every day, but for women we would just ask them to use a very, very small amount and make sort of 1 sachet last 10 days, or 1 pump just like twice, 2 or 3 times a week. So and it actually works really, really well, and it's a really effective treatment for low libido. But obviously low libido, I wouldn't just focus on just giving them testosterone. We would also look at all the other things that come with it. What they think about sex, what their sexual scripts are, what they feel, what's happened to them before. And there's lots of different sort of techniques that we can talk through just to help about that. And then HRT risks and benefits. So this is a really, really important part of a HRT discussion. And what I tend to do is always start with the benefits. And so if I'm going to give someone HRT, I'm going to say that if you take it, it's definitely going to help with all of your symptoms. It's also going to reduce your risk of osteoporosis and fracture. And that's so, so crucial to think about it at this stage of your life as you're going through that increased loss of bone mass, because this impacts your health later on down the line. And one of the things that I do in my surgery is also look at after all the patients who are over 65. And there's this clear difference between the women who have taken active control about their bone health, either by having HRT or by looking after their bone health, again, which Angela's going to talk about later. And those women are doing really well. They're active, you know, they're just so different from the women who didn't take HRT or don't look after their health generally. Also, there's a lower bowel cancer risk, there's a lower diabetes risk, and there's also some early evidence that it helps with dementia. All of this is really important as long as you start the HRT within the first 10 years of having your symptoms. After that, then some of these are the benefits actually sort of go down. So that's important to know. And then when I'm talking about risks, this is where we start talking about the breast cancer risk. And this is, Angela and I always talk about this. It's so complicated to try to explain. There's so many different ways of explaining risk to women, and you can either do it with numbers or pictures, and there's also different numbers to use. But generally, the numbers come from studies that have been going on for a long, long time. And it's just important to know that the studies that we do rely on these numbers from were actually quite flawed in that it's really hard to take the data now because they were using old types of HRT, which did have a higher risk of breast cancer. And also a lot of the women in the study were recruited were over the age of 60. And naturally, that's when you have a higher risk of breast cancer anyway. And a lot of them were started on HRT at that time. So it's hard to know whether the figures are right or not. But just generally, HRT does cause a small increased risk in breast cancer. But using the sort of transdermal or natural progesterones, it is a lower risk. And then this is where I'm going to hand over to the other Angela, and she's going to talk to you about her way of explaining breast cancer risk. And then I'm going to take over. Okay.
Yeah, that's all good.
It's all yours.
Thank you.
Yeah.
The reason we're doing this is just we both use different numbers, and that's because there's so many different ways that this has been explained, and there's different handouts that you can give to patients. And I just have settled around this set of numbers, but it's not the set of numbers that Angela likes to use, so she always feels a bit unfamiliar on this slide. So the way that I say to talk to women about it is I tend to say, look, you know, you're coming into the room with your pre-existing risk of breast cancer, you know, off HRT, you come in with a risk. And that's either the population risk. So for women in between the age of 50 and 70, we know that about 3 in every 50 women are going to get breast cancer in a 5-year period. That's without HRT. So that's just the background risk of these women that are going on to get it. And if you've got a first degree, so a sister or a mother who's got a breast cancer, then you've got a slightly higher risk than that. And if you're somebody that's got a BRCA mutation, so these are the women with the inherited forms of breast cancer, they have an even higher risk above that. But actually, neither of those two categories mean that you are more at risk from HRT. It just means that you're starting from a higher place. So in Angela's model, where she's about levels, most of us are down here, but people who've got one family member are there, people with a BRCA gene are there. HRT is going to add an extra chunk on top of that. And so then we look at the different types of HRT, and most of the risk seems to be attached to the progesterone. So the more you have the progesterone in your HRT regime, the more risk you're exposed to. So what I normally say to women is, 3 in 50 are going to get diagnosed with a breast cancer over a 5-year period. If I give you continuous HRT with estrogen and progesterone every day, I've got to give that to 50 more women for 5 more years before I'll see 1 more case of breast cancer. If I'm going to give you sequential bleeding HRT, where you're only having progesterone on some days of the month and you're still having a period, I've got to give that to 70 women for 5 years to get 1 more case of breast cancer. And if you're on estrogen only, and lots of women who have got endometriosis and have had their, their womb removed and they've had their endometriosis tissue adequately cleaned away, might be on this type. We think it's probably protective actually, but the worst case scenario seems to be that we'd have to give it to 200 women for 5 years to get that 1 extra case. There are some papers that suggest that the risk of breast cancer actually goes down in women on estrogen only HRT. The theory is that that about 7% of women, when they go on to HRT, have got a tiny undetectable cancer present, and it will probably take 6-7 years before that's going to come to being noticeable. And these are the women that when they're given HRT, if their cancer is hormone responsive, it's going to develop and grow a little bit quicker, and it's going to get noticed a bit more quickly. Interestingly, if we give those same cancers just estrogen, it seems to halt them. So those women will have a lower showing of cancer while they're on their estrogen-only HRT, but then the numbers seem to go back up again afterwards. So it's a bit weird how it works. But what we do know is the vast majority of breast cancers aren't caused by HRT, and that the risk that HRT gives you is equivalent to some of the lifestyle risks that we don't think about very much, like having a body mass index over 30, or having a large glass of wine every day, or not exercising. Those things impact your HRT, your breast cancer risk in a similar way. So what Angela and I tend to do when we're talking to women, again, is to lay this out to them and let them take choices about which of those risks they want to modify, what things they want to do. Do you want to put me on to, I'm going to do next slide, please, because she's got control.
Sure.
So next slide, please. Okay, so when we divided this up, we said that I would do the bit of the talk that was about the sort of non-HRT options. So I'm going to get Angela to change the slide again. And I think what I wanted, we have to be careful, because I think if you understand the science behind HRT, it's hard not to sound really pro HRT, because lots of women who don't understand it will have sort of been raised and watching TV and reading newspapers until quite recently, and would have felt that HRT is quite dangerous. I think inherently women are quite scared of HRT, think it's going to cause breast cancer, think you do a better job if you just kind of, you sort of grit your teeth and you get through this. So we're often trying to give the opposite view. And I think it's important that before I talk about the other options, that for women to understand that HRT is the most effective option for your symptoms of menopause. And we tend to say that, there's two reasons to take HRT. One is to deal with the symptoms that you're getting as you go through that transition. The other is to look after your health going forwards. And for different women, different things that might kill us are more prominent. And so, for example, more women die of heart disease than breast cancer. HRT is protective against heart disease. And you've got to understand that when you make your decision, you're not just treating what's happening now, you're also treating what might happen in the future. However, and I suppose it's important for women with endometriosis to realise that when you asked us to do this, we were actually we don't worry too much about endometriosis with HRT. It just needs adequate management. It needs thinking about progesterone and making sure that we're watching out for symptoms of it reactivating and that we're stabilising your levels. But there are some women that don't want HRT, that don't want to take something that is a drug-based solution. And I think it's always important to know about the other options and to know about things you can do about lifestyle as well. So we're going to talk you through them. So if you want to turn the slide over for me. Thank you. So there's various things you can do. We're going to talk about some of the non-hormonal drugs, and then I'm going to talk about some of the supplements and herbs, and then I'm going to talk about lifestyle and some of the complementary therapies. I've got to say at the beginning, the only thing that we have a decent evidence base for is these drugs on this page. So things like the non-hormonal therapies and the herbs and supplements and things we don't have a really good evidence base for. It doesn't mean that they don't work. It just means that we don't have as much research that tells us what they do that we want, as well as what they do that we don't want, the risks of it. But these drugs, so gabapentin and pregabalin, are both drugs that we would normally use in conditions like epilepsy and nerve pain. Clonidine is a drug, it's a really old-fashioned drug that we used to use for blood pressure, and that helps with some of the vasomotor symptoms. And then the other common drug that we use are antidepressants, and they often get used in women who have menopausal symptoms. And it's because all of these things affect the way that the body sends its nerve messages to effectively to cause things like hot flushes. So when you've got that change in your body temperature and your narrowed thermonuclear zone because you're menopausal, tells your brain that suddenly you're in danger because you've overheated. It has to send that message out to your body using your nerves. And this is where we intervene with these drugs to try and stop it from happening. So these drugs, they're quite side effect heavy. So often when we prescribe them in clinic, women don't always get on with them. We tend to go in with quite low doses and bring them up quite gradually, because they often cause sedation and make people feel more groggy and more foggy or retain water. But they can be effective. Most of them can be effective in about something like 50 to 60% of women will get some benefit. I have a bit of a bee in my bonnet as a sexologist about some of these drugs, because these these very same drugs impact on your sexual function, and it's really important if someone's discussing these with you that they explain to you that they may dampen down your arousal, your climax, your libido as well. But they can be a good option, and there's certainly things that you should talk about with your doctor if you're not into the idea of HRT, or if you're a bit nervous about having hormones again because you've got that history of endometriosis. There's a new drug called oxybutynin, which is more often used to control overactive bladder, and that's been shown to be effective in about half of women. So women who've got bladder symptoms with menopause might find that useful. And there's quite a lot of research being done on neurokinin antagonists. And we reckon in the next couple of years, that's going to revolutionize some of our options. And that, again, is a non-hormonal drug that is useful for vasomotor symptoms. And Angela and I, melatonin is a hormone that the body makes naturally, and it helps to make us sleepy. And we make a bit less of it as we get older. And when we have problems with estrogen and progesterone levels, that directly impacts how much melatonin we make. So it's a drug that we can usefully use for people that are struggling with sleep disturbance. In the UK, it's got a license to use for about 3 months over the age of 55. I sometimes use it more off license with patients. It can be really useful. Can you pop me onto the next slide, please?
Sure.
Thank you. This is herbs and supplements. So there is guidance. The British Menopause Society recognises that there is some evidence that suggests that these sets of treatments can work. So phytoestrogens are plant-based chemicals that behave like estrogen in the body. They're either structurally similar to the estrogen that we make, or they will behave like estrogen and stimulate estrogen receptors in the bodies. And they are drugs like red clover, soya products, and things like flax seeds. And the information on these kind of substances has really been derived by looking at countries who've got diets that are really high in these kind of chemicals, and the fact that their women in those countries report less symptoms around menopause. So they've drawn that kind of conclusion that it might be something dietary that's doing that. And we've got, some evidence that suggests that they work quite well, and they seem to have a good safety profile. We have concerns, I think, about things that act like estrogen in the body in terms of whether they will be an issue potentially unopposed for women who might have endometriosis or women with breast cancer histories. And what we don't know about these drugs or these supplements is whether they need to have that progesterone opposition to prevent against some of the problems that Angela was talking about in terms of unopposed estrogen stimulation. So I have women that are really open to this and want to give it a go. I think my personal approach is that I'm happy to support anyone doing something that they would like to give a go and try. I just think it's quite important to make sure that you have a good quality supplement, that you know that it's been, that what's in the bottle is what you're expecting to find in the bottle. Black cohosh is a good example of that. There was research that showed that black cohosh caused liver damage, and it seems to be because it was contaminated with blue cohosh, which is quite harmful. So although it's a useful supplement, and it can help you with your hot flushes and with your menopausal symptoms, we've just got to be careful to recognize that these aren't inner things. I often, when I'm talking about drugs and side effects for patients, I tend to say, look, if something does something that we want it to do in the body, it's very likely to do something that we don't want it to do in the body as well. And it's always that individual balance between how much good stuff are you getting and how much bad stuff are you getting from any chemical that you put in. And I think we have to recognize that herbs and supplements probably need to be thought of in the same way, but they can be useful. And for women that have got less options, it can be some of the only things that they can do. Can you turn me on to this one again?
Sure.
Thank you. And then I've just got a list on this page, and my pronunciation of some of them is not brilliant, but these are the things that we've got some evidence of, but not very much. As you can see, I've written in every box that we don't have a lot of evidence for these chemicals. They've all been discussed quite widely in menopause communities, and I'm sure lots of women here will have heard about them. Some of them have got more science behind them than others. St. John's wort is used in other countries, for example, to treat depression. I had a lady in clinic yesterday while she was waiting to get to menopause clinic who'd had some good success with St. John's wort. The problem with that drug is it's what we call an enzyme inducer. It stimulates the liver to clear other drugs in a different way than it normally does, so it can interact quite a lot with other things that we might give you. So these are things that you'll hear about, but we have a really poor evidence base for their efficacy. So I would just advise a little bit of caution if you're going to try some of these herbs and supplements. I think the exception there potentially is oil of evening primrose, in that it's been used widely for a lot of years for things like breast tenderness and so on. And if you're using it for that indication as you go through menopause, you might find it useful for that, but it doesn't seem to have any efficacy for vasomotor symptoms like flushes and so on. Next slide, please. I feel like I'm in the coronavirus thing saying this. And then there's cognitive behavioral therapy. So if we go to the next slide, we'll talk about this, because this does have an evidence base. So Angela and I have both been trained by the British Menopause Society for CBT for menopause. And I have to say, when I first heard of CBT for menopause, I kind of rolled my eyes, because I thought that maybe they were going to try and convince women that they shouldn't worry about this. And that seemed really sort of patronizing, that that was going to be the approach. But interestingly, there's been loads of work done on this approach, and it's got some good evidence behind it. And the way that I normally explain it to women is, a lot of the time in life, it isn't just what happens to us, it's the meaning that we derive from what happens to us, or it's the story that we tell ourselves about, you know, why something is important, or what this thing means for us. And if we go into menopause and we don't know a lot about what's happening to our body, and we feel out of control, we don't know why we're not sleeping, we're going into meetings and our brain is foggy and we can't concentrate and work well at what we're doing at work. Actually, anecdotally, lots of women leave marriages, leave workplaces. You know, they really struggle as they go through menopause, because they think that they are losing their grip and that something is inherently wrong with them, and they've become less capable. And the essence of CBT is, again, this idea of educating women, treating them like grown-ups, and explaining to them what's happening to them, and then giving them some tips and hints and approaches that they can use to know what to do when they get some of the more troublesome symptoms. So it's over about 6 sessions. It's done in small groups, because there's evidence that if we share our symptoms in small groups, we tend to get something from talking to other people. Like tonight, you know, if we share this stuff, we feel better. We know that we're not alone and we're not going nuts. And there's a couple of sessions about just generally what happens in the menopause. And then there's a session about sleep. Sleep's a major problem for loads of women, because estrogen and progesterone are quite intimately involved in our fight-flight autonomic nervous system and in our sleep cycling and patterns. So one of the things it does is it talks to us about how we have sleep cycles at nighttime, and stage 4 sleep is our deepest sleep of the night, and it's where we get most of our regeneration and recovery. And there's good evidence that in women going through menopause who are sleeping less well, they're taking their stage 4 sleep in the first 2 or 3 hours that they go to bed at nighttime. So just knowing that alone helps you to understand that your body is already working around these hormonal changes. It's making sure that you get the sleep that you need to function, even if you wake up at 4 in the morning. And actually, we know that on the next night and the next night, if you're already sleep deprived, your body will take more stage 4 sleep to try and replace what you've missed. So that takes the anxiety away from the sleeplessness. Anxiety is not just a feeling, it's a chemical chain of reactions through our body that makes our heart race faster, charges our muscles so that we can run away from a lion in a cave back in prehistoric times. You can't sleep if you're anxious. So we have to take the anxiety out of sleeplessness to succeed in getting people to sleep better. And the same sort of principle is why it works around hot flushes. Hot flushes are made worse by things that increase our stress. Cortisol, the stress hormone, actually displaces estrogen at some of its receptors, so it can make the symptoms of menopause worse. And when we activate anxiety, when we go flush in a meeting and we're struggling, then we know that we start to get sort of a reaction to that, and we start to panic about what's happening. And that again sets off all of these mechanisms, supercharge our muscles with adrenaline, make us really edgy, off go the palpitations, and we lose control even more. So we teach paced breathing, which is, you can go and Google it, and women that are struggling with symptoms can just go and look at it on YouTube. Soft belly breathing or paced breathing is a bottom-up approach to anxiety. So this is treating anxiety by making your body act as if it's relaxed. So you take about 6 breaths a minute, and your brain monitors all the time how your body is. And when it receives the messages that your body is relaxed and safe, it flips your brain chemistry to tell you that you're actually quite relaxed and that you're safe and things are okay. So it's associated with a decrease in stress, a decrease in that fight-flight mechanism, and it helps with the impact of vasomotor symptoms. So like everything, it's not massively widely available at the moment. One of the things that Andrew and I want to do when the clinic is off the ground is to sort of run sessions of this in an online way, because we think that the reach of this stuff would be really good. We're doing some work with Maggie's, the breast cancer charity, around trying to help them implement some of this stuff for women with breast cancer histories. But understanding this kind of stuff is paced breathing. And Nicola's asking, was it paced breathing? It's paced, P-A-C-E-D, paced breathing. There's quite a lot. We use it in other situations, again, with trauma and other sort of mental health issues that some of us have. The similar approach of body up approaches, where you teach your body to relax, work brilliantly in women that are traumatized, and it also works brilliantly in these situations. I think we forget that we're animals sometimes, and that our systems have been designed for prehistoric times when we weren't dealing with the stresses that we've got now. And when we activate those systems, you know, that's why we feel so awful. Can you put me onto the next slide, please, Angela? Thank you. I've already spoken about all this, haven't I?
Yes. We'll
so there we go.
The
okay, thank you. So I think the final chunk that we've got here is about alternative therapies and diet and exercise and lifestyle. So this is because I think these things really are, rather than alternative therapies, I think of them as complementary therapy. So I've got a background, I worked for 10 years in hospice medicine. So I think my being drawn to this sort of holistic approach probably comes from spending a lot of time doing that and just doing whatever works to make things better. And I think if we think of these alternative therapies as being add-ons to other things that we're doing, we can make a huge amount of impact for women. So like we've said before, anything that reduces your stress, anything that reduces how bad you feel as you go through this, that builds your confidence, that helps you to understand how your body works and how you can change how you feel, and improves your sense of general well-being, is going to improve not just your menopause symptoms, but actually the same is true for women who are struggling in the middle of an endometriosis journey or whatever. These things are true throughout our lives, really. So again, there's not a huge amount of evidence, but we know that for things like acupuncture, auricular ear acupuncture is quite effective, and it can help to reduce stress and anxiety and flushes. Some evidence for things like reflexology and homeopathy. And again, if you flip to the next slide for me, exercise is something that I think women sometimes feel as a stick to beat themselves with. I think we think about exercise so that we have, you know, a nice tummy and good glutes and we look nice in trousers and things, but exercise is actually really, really helpful, and we should think of it as time for ourselves, and we should try and find exercise that we love and that we look forward to doing, and then we get all the benefits from it. And it's really useful for women going through menopause. So not just from a symptom point of view, but if you look at menopause as a pit stop where you kind of go, okay, I'm going to have to think now about the next 20, 30 years and how I'm going to age. It's the single most useful habit to get into, because from your mid-30s, you're losing muscle mass. And that loss of muscle mass is what's going to make you fall when you're 70 or 80, because you won't stabilize your joints and you'll topple over. And, you know, we know that women that fracture a hip age 65 have a 50% likelihood of living in non-independent houses. So living in care a year later. You know, it's that important that you don't fall and break your hip. So if there's a single message tonight, it is bone health, muscle health, you know, looking after yourself. It's not to look nice. It's not that myth of only doing it so you look 30 when you're 50. It's doing it because it's going to give you an independent life and keep you strong. So choose what you like. There is evidence for sustained aerobic exercise. There is evidence for things like yoga and cold water swimming, which doesn't appeal to me remotely. But I think the most important thing is finding something that you enjoy, that you're going to look forward to doing, and that you're going to incorporate into your life. When Angela and I go to the annual update for the science of menopause, the annual symposium, there's a guy that speaks about obesity, and he always has a cluster of, because most menopause doctors are kind of in middle age, and we all cluster around him at the end to find out what to do about not gaining weight in menopause. And the key thing that he always talks about is muscle mass. So making sure that you can keep your muscle mass up, making sure that you have good quality protein in your diet, whether it's plant protein or animal proteins, but a decent protein intake, and exercise is really important. Can you pop me onto the next one, please? And yeah, this is just a summary of other things. So we look at this, my bee in my bonnet is often about urogenital health, so bladder health, pelvic floor health, sexual health. And if there are top tips that I would say for women as they go through this stage, Make sure that you keep your stress and anxiety down. So discover mindfulness. It's not just a naff word. It actually is really important about getting you out of your head, into your body, and reducing your stress levels. There's a good app called Headspace, which can be downloaded, which can help you to learn how to shush your brain and get into your body. Look after your bladder. So reduce your alcohol and your caffeine, strengthen your pelvic floor muscles, because you're going to really need them in the next 20 or 30 years. And it's really important for your sex life. If you've got a nice, strong pelvic floor, then you'll have a better quality orgasm. You'll bring more blood into that part of your body, which is going to keep it healthy. Make sure that you use lubricants if you're having sex. Don't put up with pain. Loads of women put up with consensual pain during sex just because they don't want to upset their partner or ruin the flow. Make sure that you talk about it, because you set up bad patterns in terms of your own reflexes and muscle contractions that make it worse. Eat well, stop smoking, and alcohol, although a little bit of it is good for us, it's really associated with lots of cancer risk. So be cautious with it and make sure that it's a small part of what you do. And then I think it's bones, isn't it, next? Yeah, bone health. So I'm going to let Angela finish after this, but because bones are really her area of interest. But as she said, bone density falls from your 30s really, but it accelerates as you go through menopause. I think you lose it, is it 1 to 1.5% of bone mass a year as you go through menopause? 2% as you go through menopause, and then it drops back slightly to 1 to 1.5% afterwards. Some women ought to have a bone scan, especially if you're going through a premature menopause because of things like drug treatments, cancer treatments. If you don't replace the estrogens, then it's important that we check your bone mass and we look after your bones. If you have a family history with a mum with osteoporosis, or what we call a fragility fracture, where a really small impact has caused a bone break, that might mean that you're more at risk. If you've had long-term steroid use or an eating disorder or a very low body weight and your periods have stopped for a part of your life previously, all those things might mean you're at more risk of osteoporosis. And it's the great forgotten disease. We just don't think it's important, yet like I demonstrated before, it's hugely important for your independence, so you're not living in a home prematurely. And some drugs stop us from absorbing the calcium that we need well. So I've given a little list there that's I think this is all being recorded, so we can come back to it. And then on the last page, I think if you can flip me over, it's just the things that you can do. So another, HRT is indicated to prevent osteoporosis. So if you're menopausing early, you should really seriously consider HRT to keep your bones protected until at least the age of 50, 51. And then weight-bearing exercise, and that is, I love cycling and swimming, neither of which are any good for bone density, but things where you impact your bones tells your body that they need to lay down new bone and keep it strong. So skipping, jumping, walking, dancing, anything. Make sure that you have adequate calcium and vitamin D in your diet. So if you exclude a food group, make sure that you're being careful to replace the calcium intake. Vitamin D deficiency is endemic in this part of the world because we don't get much sunshine and we don't get out to get it on our skin. Is it 20 minutes on your forearms from April through to October?
October, yeah.
To make sure that you get adequate vitamin D. And because we are better at using sunscreen, that's great for melanomas and skin cancers, but it means that we're not absorbing vitamin D. So in amongst the many list of things I'm telling you to do, try to remember 20 minutes without sunscreen, then apply it. If not, just get a supplement, because that will make sure that you're getting it in. And then, boringly, stop smoking and reduce alcohol. They also affect your bones. And I think we've gone through a huge amount of stuff. So this is a good chance now to ask questions, and we'll do our best. Yes, I wish if a villa in Spain could be prescribed, I would be out there practicing in Spain myself.
That was brilliant. I really enjoyed that. And you've been absolutely fantastic and provided lots of us with lots and lots of information. There doesn't seem to be any. Oh, is that Nicola again? Oh no, this is a new person. I love Nicola because she puts up so many questions and stuff, but this is someone new. This has been really great and helpful. Thank you so much for your time. I have quite a long and complicated medical history, and I'm seeking a second opinion, RE, endo, and induced add back HRT. Do you have a private clinic that I may be able to make an appointment for?
Very, very soon.
Yeah,
we are. There's a
very soon.
backlog at CQC. Basically, they
Yeah.
tell you it's between 8 and 20 weeks to register. So we are just waiting for them to stamp the forms. So sometime in the next, hopefully 6 weeks, we hope, we'll be up and running.
If you go to our website, www.spicepearhealth.co.uk, you can just register your name, and then when our clinic's open, we'll send you an email and let you know that we're ready to go.
Yeah,
So, yeah.
I'll put up the link in a.
Thank you.
I will do that now. Actually, I can do that now while we're on this.
We're online. Nicola's asking if we're local, but we're online, so it means that you can access us from anywhere.
Yeah,
Yeah.
I'm a GP in London, and Angela's up in Yorkshire, so
Yeah.
we can do it really from home, in the evenings or in between clinics. Yeah.
Yeah, I'm struggling to find anyone local to us, Nicola, that are any good, to be honest.
There's in terms of the menopause side of things, there is the British Menopause Society, the people that trained us, and there's a sort of a list of specialists that exist, but it's about getting somebody that's got that sort of wider, broader knowledge as well. I think the reason that we thought we needed to do something was that nobody was doing chronic disease stuff, nobody was looking at it holistically, no one was talking about sex, and we just thought it was really important to sort of put that in as well.
Yeah,
I always love to look at it as this is my real opportunity, that one opportunity when that lady comes who's got menopause, to talk about all these things. And it's just from my experience of looking after those patients over 65 and saying to myself, I don't want to be like that, for some of them. What can I do? And it made me realize that actually, if we go back to what women do around the time of the menopause, or what choices they made around that time, and if they started looking after their health there, that's the earliest, or sort of the kind of earliest stage you can start doing these changes and still have that benefit. It just like one of those mind blown moments when I just realized actually that is the most important point to talk to women. And unfortunately in our NHS, we don't have those checks, for women. It would be wonderful to have, say, 40, to have everyone to come in and have a chat with their GP about this stuff, and and start talking about long-term health, about menopause before it happened, just to preempt them, talk about things that they could do and when to approach GPs. And that's in the ideal world. Maybe they might start doing that now that everyone's talking about it, but that's what Angela and I do in our clinics, in our NHS clinics anyway, and you can see the unbelievable benefits for women, and such positive feedback from women when we do that with them. So yeah.
Yeah, it's what we preach as well. It's that holistic treatment of looking at a whole person.
You're not just a womb. You're not just a exactly.
Yeah, there's so many, and I love cold water swimming, so I'm happy about that.
I said this, but I did once get into, there's a massive Lido in Cambridge that was absolutely freezing when I went in September when I was doing my sexology training. And to be fair, it's one of the biggest highs I've ever had afterwards. Yeah, poor Nicola, I'm not even a womb. Exactly.
Me neither.
It is that, but I think anyone who tells you that there's a one-hit wonder, one of the things we're concerned about with the conversations happening around menopause is it's good to improve access, but it's not good to say that the same thing suits everybody. It dumbs it down. It doesn't. There's so much about, we always start, somebody asked about which HRT and how do you know. There's a gold standard that we always use, these body identical chemicals that have got the lowest risk and the best sort of benefit profile. We start there, but then you have to tweak and see what's happening. So I think Nicola had asked earlier about why does some people not absorb it, and there's all that individual variation about whether you're going to get your estrogen adequately through your skin. Are you putting it on properly? Do we need to change the brand? Do we need to change to a spray? You need somebody that knows all of that stuff. Otherwise, you're just going to come up against a wall.
Yeah, some women just don't absorb, and it's nothing to do, it's just to do with the way that their skin is, and that preparation might not be the right thing for them. But we'll only know once we start something and then give it a try. And that's the same when I go back to using contraceptive pills with younger girls. I just have to say, you just have to start somewhere. And then once you've tried it and you tell me what you're feeling with it, then I can kind of go to the right one, and eventually we'll get to the right one. But it's trial and error, and it's the same with HRT. And this is where I think if you get a GP who's not comfortable with it or not confident with it, then you're going to get stuck. And then then they're going to get stuck as well.
And give up on
that
it.
knowledge ends.
Yeah.
But,
It's all about opening that narrative again, isn't it? It's getting a GP that you're comfortable with. And I am so hot on it. I'm like, if your GP won't listen to you, go and see a different GP.
Totally.
That is what I'm constantly telling people. I'm like, if your GP won't listen or isn't willing to work with you, go and see a new GP. Go to a whole new different clinic if you have to, like, until you found that one GP that's willing to work with you, then it's
and it's not just, it's secondary care as well. I mean, I always say that, you know, I've had, even as a doctor, I've had experiences with my children, with my own health, where even when I go in and I know what's wrong, I've still been ignored. I've still had them scan the wrong bit of my son when he had sepsis because they didn't listen to me saying his knee was sore. It's not, it's I don't understand what's changed with some people, whether it's with the busyness or whatever, but there's what you don't necessarily need somebody who knows everything. You need somebody who's going to listen and is prepared to work with you to find the answer. That's the most important thing.
Yeah, I was talking to you yesterday, were we talking? And I told you that my GP held his hands up and went, I have no idea. You probably know more than I do, but I can put you in touch with the people that know. And that's what you want. Good. You want someone
that's
that
a good
just
GP.
says, I haven't got a clue, but I'm going to put you on the right path.
Yeah.
We're not supposed to know everything. We're supposed to advocate for you to help you find the answer. And I think that's the important
bit.
With
the navigators. Can you navigate that whole NHS system?
Yeah, and I just think some doctors, and I'm not saying all of them because it's not all of them, and in primary and secondary care, they're gatekeepers rather than like navigators. And it's so annoying. It's so annoying. So it's great when you do have a little bit of information, you're armed with a little bit of information yourselves, and you can advocate for yourselves that way.
Yeah.
Absolutely.
So has anyone got any more questions? Or have we managed to answer it all?
It's a very long presentation, Angela.
Yeah.
Can I ask a question about pain relief for endo? You can. I don't know whether we'll be able to answer it, but you can.
We both do women's health, so yeah.
Oh, well, there you go. Yeah, absolutely.
I mean, generally with pain relief, I would always use the principles of starting at something very simple and then working your way up. There's different levels of painkillers, and as you work your way up and as they get more stronger, you get more side effects. And then what you're doing is just constantly counteracting the side effects of those painkillers. But generally, I think for endometriosis and period type pains, it's more anti-inflammatories that I would tend to use. I don't know about Angela.
Yeah. So so that's where the hospice bit is useful. So pain control is a huge bit of what we do in that kind of setting. And yeah, I think you're right there. The simplest thing to do, because the reason you get the pain is to do with prostaglandins, and anti-inflammatories block them, so that if you can tolerate them, they're the most useful thing to use for it. And there's all different kinds, and one of my favorite rheumatologists gives patients a bit of a shopping list of all the different anti-inflammatories and lets them try. And I think you're kind of going, actually there's individual variation between side effects and what works for you. And I think that approach of having somebody who, again, is treating you like an adult and saying, here is your list of things that you can try. You tell me what works. Let's work together to find the right solution. Is the spray, I think someone's already answered them there, is Lenzetto.
Oh, I did that.
Yeah, I was thinking there was another one there. Diclofenac and fentanyl.
Yeah, that's what I was making the face at.
That's pretty strong.
Mega. Yeah. The problem with opiates, so opiates, you can get, with cancer, we had this as well, and I've got to be careful how I phrase it because I don't want to make people worried about them. But pain is really odd. It doesn't behave like you think it does. It doesn't correspond directly with tissue damage. And there are certain situations with chronic pain where the brain amplifies it. It turns up the signal. And you have to get very cautious about not chasing it up further and further up doses. And things like opiates, so things like fentanyl and morphine, can produce allodynia, which is when the nerves start to tell you there is pain when there isn't.
So
you've got to be really careful if it's not working.
I would also think about maybe going to an actual pain clinic, and
Yeah.
That's what I was
not
gonna
just
say
more,
next, yeah.
not just more for the tablets, but actually just more for the psychological side as well.
Yeah.
And what they do is they teach you this, to help you understand pain and how to manage it. And I think it goes back to the same thing as the CBT for the menopause. Once you understand how pain works in your body, then you come to accept it and you come to find a way to manage it. And some of my patients who've got chronic pain and been to these courses, it's really changed their outlook.
Yeah.
And they've actually gone on less painkillers because they've learned to manage it better.
Pain is total pain, and there's some when you get into what your brain can do in terms of not corresponding with what's actually happening, it's astonishing. So that you get phantom pains in limbs that don't exist anymore. We get people that have pseudo epilepsy, they're not epileptic, but distress has made them have seizures. Our brains are incredibly evolved, and pain is exactly like the CBT approach. You've got to sort of look at it from a holistic perspective and understand it. So yeah, I would completely agree. Pain specialist clinic is the way to go if you're really struggling.
So there's someone just wrote, is there somewhere I can get CBT for menopause? So like we said before, it's potluck really where you're going to get it, unless you've got someone that's trained and offering a local service. Just so that you know, in my menopause clinic in Kings, what they do is the consultant just tells everyone to get the book, which is not great, but it's written by Myra Hunter and it's called, I can't remember, it's CBT for menopause. Really, you can get it on Amazon. But it talks you through the whole 6-week course and explains everything. So that's what he tends to do, because even there's no, he's the head of the British Menopause Society, but even there he doesn't have a CBT group to send patients to, which is terrible.
Nicola, I'm working really, really hard with all of the different talking therapies around our areas at the moment. And one of the things we're looking at really directly is women's health and what needs to be done around women's health and CBT, and doing specific women's CBT sessions. So it is definitely something that I'll probably be bringing you on board with, because I think you're the most qualified person for it. So yeah, next time we're having a chat, I'll be bringing you on for it.
We'll advise you.
But you two were absolutely fantastic in explaining pain in a way where
Sorry,
a lot of
I found the book. Sorry, it's called Managing Hot Flushes and Night Sweats.
There you go.
And it's by Myra Hunter, MyraHuntr, and it's on Amazon.
There you go. She's on her Kindle already. Yeah, you two are really good at explaining pain in a way that a lot of people have come to us and gone, my doctor's told me my pain is all in my head. Because they don't understand how to explain it in that way, where it's not all in your head, but there are definitely signals.
That's the name of a book. So one of the best books that I read is called It's All in Your Head, which is about, have you read it?
Yeah.
It's a brilliant book, because I think this is back to the trauma thing again. The way that we think we control our bodies is not quite the way that it really happens, and our bodies are really good at sort of holding memories and amplifying certain signals and damping down others. It's really complicated, actually.
So Emma, her name's not Ben, it's Emma.
Not Ben.
Had a total hysterectomy in December, and they left one ovary. She recovered, but she started getting pelvic pain and back pain when ovulating and when she would be due on. I'm worried the endo may be growing back, but this seems really quick. And any books you suggest on managing endo and diet? Don't read books on endo and diet, because they are not good. There is a PhD starting in September that is studying specific endo diets and stuff. So wait until the stuff comes back from that, because a lot of it is based on FODMAP diet, and it's really, really strict and just not worth the stress, because you don't know what's going to work and what's not. So wait until the proper studies come out on endo and diet, and the rest I'll put back to you.
I think I would have said the same thing, actually. We feel the same with the menopause space. It's quite a lot of myth and people making money out of certain things and writing books when they don't know very much. And it's probably part of why we've started to speak up a bit more, because we felt frustrated at some of the stuff that was being peddled by people that don't understand it. You're vulnerable when you're struggling with something, and the answers aren't straightforward. And I think anybody that tells you that just cutting out wheat is going to transform your endometriosis is not being fair. So I would agree, get something with scientific background.
We've also noticed that there's loads of people just popping up who are now menopause experts in all sorts of various areas, and just jumping on the menopause bandwagon. And those are the people I'd just be a little bit worried about, because they weren't doing it before, and now suddenly they're experts in this area. So
it's really prevalent in the endo world as well.
I bet it is.
I'm sure as well.
It is crazy, and they're like, you can cure your endo by drinking my milkshakes, and it's like, no.
Exactly. But that's back to this myth of a green smoothie solves everything, isn't it? If only we behaved ourselves better and ate better, and actually that isn't fair. It does something, but it's
and it puts so much stress on you, and it doesn't work because you're like, well, why is it not working?
It's a self-blame, and that's exactly.
Yeah. Right, I'm going to wrap it up, because I'm sure we would go on forever if we could.
I've gone really warm in my room, so I need to get some air out. I'm getting really red.
Thank you so much for joining us. It has been fantastic. And if you ever want someone to come onto your podcasts or anything, I'm more than willing.
Oh yes,
we are starting one. Actually,
definitely.
we've recorded our first, so that's a really good idea. We'll bear you in mind.
That's exciting.
We're doing our own podcast now, so we're just practicing with ourselves at the moment. And then we definitely be inviting people in.
Yeah.
So I will definitely subscribe.
Great.
Thank you so much.
Thank you for having us, and thank you for listening to our talk today.
It's been a pleasure. Thank you, guys.
Bye-bye.
And everyone is saying thank you in the chat.
Thank you. Thanks.
It's a pleasure.
Right, lovely. Right, and I will see you soon, everybody.
Thanks, Jodie. Bye.
Bye.
Bye.